diagnostic pearls in the biometry and the IOL path calculation. Biometry in ophthalmology is the method of applying optics to the eye. Biometry is the key to achieve the desired post-operative refraction after cataract surgery, which needs accurate IOL power calculation by accurate biometry. There's a long journey of biometry from starting with the ultrasound, then optical biometry, and now it is SWIFT source biometry, as in JAI's IOL Master 700. The major factors affecting the IOL power calculation are the corneal curvature measurement, that is keratometry, central topography, axial length measurement of the eye, estimation of anterior chamber depth, personalized A constant or surgeon's factor, and prediction of effective lens position. What is keratometry? It is known to all of you, but I want to highlight some points that better to take the readings in the dioptric power in plus notation, as it is important in the incisional management of astigmatism using coupling effect. We could not ignore the posterior keratometry reading, otherwise we will land in post-operative surprise. IOL Master 500 gives only the anterior keratometry, so along with the Barrett, which takes care of the posterior keratometry to some extent, gives a more satisfactory result. Now, IOL Master 700 has a combination of both anterior, this is telecentric keratometry measurement for the anterior corneal surfaces, and SWIFT source OCT technology to directly measure the posterior corneal surfaces. In this slide, we see that in the upper part, there is a telecentric keratometry reading for the anterior surface, and the lower part, it is a SWIFT source OCT technology for the posterior corneal measurement. So in combination, we get the total keratometry reading. What is telecentric? It is distant independent, motion independent, and independent of focus, and directly radius measurement and visual assessment of dot for tear film integrity. Now is the interface of the JAI's IOL Master 700, which shows the anterior keratometry, posterior keratometry, and the total keratometry. Now, central topography is very important to get the desired IOL post result. The central topography is integrated in the JAIL Master 700, and it is very important we get the central topography along with the other measurement. It gives a clear idea about the central topography of 8 to 4.8 millimeter range. With the other there is no changes in the workflow because it takes the reading along with the other measurements. The corneal irregularity in the central optical zone is regarded as the visually relevant. If you can compare the JAI's IOL Master 700 with other topography, it is excellent comparability. Here in the slide shows the central topography of the JAI's IOL Master 700 and the Galilei G4. Here it is with the rule astigmatism with the JAI's IOL Master 700, and same is the Galilei. And thus here we can advise the patient for the toric and multifocal IOLs. But in some cases where the central topography of JAI's IOL Master 700 shows against the rule astigmatism, but so the Galilei, though central area shows against the rule astigmatism, but the peripheral part, as there is some flattening, and this indicates the pellucid marginal degeneration. Here, the advice to the toric IOL is okay, but for multifocal or any other diffractive IOLs, it is not advisable. Now, there is some very important is the angle kappa. It is also called Chang varying chord. For IOL with diffractive rings such as trifocal, bifocal, or multifocal, to some extent the extended depth IOLs, we want to place the IOLs in the diffractive rings in the concentric with the center of the patient visual axis and as well as the center of the pupil, as influence the performance of the diffractive rings. Ideally, this will give the best visual performance and the best satisfaction of the patient if we place it in the central position. The first slide shows the visual axis and optical axis and the angle kappa and angle alpha. If we see through the microscope, if the three centers, that is optical center, pupil center, and visual center, are in very close approximity, we can assure that here the diffractive IOLs are will give the very good result. But in the below sides below, that is angle kappa, here there is a difference between the centers, and the angle kappa, which is angle between the visual axis and the people's center of the people, is very apart. We have to pay attention to the angle kappa, because if its value is greater than zero point 0.6, then the patient with diffractive lenses will have the halogen glare. There is an interface of IL Master 700 showing the angle kappa, that is Chang varying chord, along with the measurement of the XY coordinate. In these slides, we show that angle kappa, which is summation of X and Y coordinate, if it is less than 0.6, then that is angle kappa reading, then it is good for all diffractive lenses and toric lenses. But if it is more than 0.6, then we should not avoid the diffractive lenses like multifocal, trifocal, or bifocals. For the axial length measurement, that ultrasound contact biometry is obsolete. It is almost history. The standard biometry is optical biometry, immersion ultrasound biometry, and B-scan biometry when necessary. Optical biometry gives the most accurate reading, is easy to get, and easily available to us, almost accurately reproducible. So it is our first choice. In the immersion biometry technique, the ultrasound probe does not touch the cornea. So there is no corneal compression, but it gives the reading up to the internal emitting membrane, not up to the retinal pigmentary epithelium, as shown in this slide. Thus, there is a difference between 150 micron. It is more than in optical biometry. So if we get the immersion biometry or axial length reading, we can convert to the optical biometry reading by Haig's calibration, as shown in this formula. Now, in some cases, optical biometry will not be used, and where it will be advised to use the immersion biometry in the mature cataract with a strong PCSC, fixation difficulty, tremor and nystagmus, significant corneal and vitreous opacity, RPA defect, and pigment epithelial detachment, and physical disability preventing the access. Fundus examination is the utmost important to get the post-operative result. Now, in IOL Master 700 gives us some idea of the macular pathology. In this slides, there is a macular hole, and in this slide, there is this star macular degeneration. So in these cases, it is very difficult to get the very good result. Now, precaution before the IOL implant is more important than its indication. Otherwise, dissatisfied patient will after surgery. The thorough preoperative examination helps us to rule out the following pathology: dry eye and meibomian gland dysfunction. As the tear film is the first refractive surface of the eye, so tear film integrity is important. If it is not, then for dysphotopsia will occur, and so the preoperative investigation and along with the treatment is very important before surgery. We can also go for the corneal pathology detection, pupillary abnormalities. Pupillary abnormalities, it is very important in case we use the trifocal, bifocal, or multifocal lenses. For general weakness also important if it is so that capsular bag subluxation with the IOL decentration in future may occur. Glaucoma and optic nerve pathology is a not contraindication, but in case of diffractive lenses, it should be avoided. Macular disease, there is this reduced contrast sensitivity of the eye. So in these cases also, diffractive lenses are like multifocal, trifocal lenses should be avoided. Amblyopia and nystagmus should not be the ideal case for multifocal lenses. There are many situations in which we should have to validate the length and keratometry measurement. There are numerous situations in there. It is very difficult to discuss all the points in a very short time. But if it such occurs, then we should validate the axial length and keratometry with the same instrument or with the help of other instruments. Now, come to the IOL formulas. There are many IOL formulas in different situations, but the result is not perfect. No human can ever write the single formula that can take account of every adjustment and variables. So previously we take the help of of decision tree and then sort it that which formula it is suitable for this patient. But nowadays there are many other formulas. But for the formula, the effective lens position is the main problem. It is a post-operative IL position within the eye behind the cornea. It depends upon the accurate biometry along with the preoperative capsular size, severity of the cataract, post-surgical capsular contraction, and thus, even if there is a holiday formula for expected effective lens position, but it is still not accurate and it is still challenging issue when we use the effective lens position in our formula. Recent IL formula of the which for the accurate results are Oleson, Keynes formula, Barrett Universal 2, Hill RBF, and Rada Super formula. The Oleson formula is in the new concept for the ray tracing assisted intraocular power calculation with newly developed concept of C constant. C constant can be thought of as a ratio by which the empty capsular bag will encapsulate it and fixate an eye while following in-bag implantation. It is free from expected lens position, so it is good. Now, Keynes formula, as British Ophthalmology Journal claims that it is more accurate than other formula, but it needs large cohort study and validation. Hello?
Yes, sir.
Hello, what is the problem?
You can again reshare your screen.
Yes. There is no problem.
And another 5 minutes after that, we have got 2 more speakers, please.
Okay.
Or if there is an issue, we can have a discussion, right?
Okay, just.
I think there's some this software.
There's some issues there.
Okay, right. Just try again. Yeah.
Yes. Whether
Yeah. Agarwal, 5 minutes, and after that you can.
Okay. I am coming to the point again. Now, yes. Now, I have discussed about the Keynes formula. Now, Barrett's universal formula, it is based on the theoretical model considering the change in the principal plane along with the variety of ions by means of lens factor. But in this formula, expected lens position is used, but how it is calculated, it is kept secret by Professor Barrett. So, but it is very popular and gives the very accurate result. Hill RBF formula with a version 3. When we upload the data of the patient, Hill RBF finds a distinct pattern in apparently random clouds of data points already created by the large number of cases. So it is a pattern recognition based on the artificial intelligence. It is a purely data-driven, free from limitation of lens position and free from the limitation of inherent standard formula. But here there also the limitation, which gives the result as out of bound. With the data showing the prediction value may not match with the target outcome within 0.5 diopter or not enough data to validate. This is the interface of the Hill RBF formula. Now, LADA super formula, based on the creating the LADA super surfaces using the sweet spots of 4 formulas: Hopper Q, Holiday 1, Holiday 1 with the Van Koch, and the Higgs. All the sweet spots amalgamated to form the LADA super. This is the interface of the LADA super formula. As soon as we enter the biometric parameters, then we get the result instantaneously along with the 3-dimensional graph where the surgeon can know what type of eye he is handling. Now, if we compare the LADA super formula with Barrett formula, if we plot the 2 graphs, then the blue area shows the identical result, but red area gives the different result. Here again, the LADA super formula gives the better results. Now, which formula to use, whether it is multiple, whether we should depend upon the anatomical consideration? These answers are very clearly given in the this American Academy of Clinical Journal, and here we can get the answer which formula of most accurate in all range of axial length. Here, the histogram shows the Barrett and Oleson formula gives the maximum number of cases within 0.5 diopter of this error, and here the prediction error is very low. So they are good. And now, if we consider the different IELTS power, here again, the Barrett and the Oleson, that is in the red line and the violet line, gives the horizontal, almost horizontal line, that shows the less prediction error. Similarly, if you consider the axial length, here again the Barrett and the Oleson gives the very good results. Which formula is the most accurate in all range of keratometric value, and which is the most for all range of anterior chamber depth? Here again, in both cases, Barrett and Oleson gives the very good results. Now, what is the effect of Wang-Chok optimization? If you add the Wang-Chok optimization, here again the Barrett and Oleson gives the minimum prediction error, so they are good. Now, in the patient for post-operative surgery, post-refractive surgery, the IOL ACR is the good, but Barrett 2K formula is better. It is shown in this article also. Now, what is the status of biometry in the silicon oil field? The ultrasound gives not accurate result. Here again, the optical coherent biometry with silicon mode gives a better result. Now, to conclude, the Barrett Torre calculator along with the Barrett TK universal 2 is the most popular formula accepted, and Hill RBF and LADA Super, it is artificial intelligence-based formula, will give the very accurate result and constantly improving over time. It gives almost 95% accurate result. Swept source biometry is the instrument of my choice. Thank you.